Hello, and welcome to the Doctor's Inn. I'm Marcia Boyles, and I'm delighted, as usual, to introduce the principal of the show, Dr. Sethi, who is a primary care provider at our Green Spring Medical Center. Dr. Sethi, I think we have a really interesting topic this morning. We're going to be talking about sleep, and since we all do it, I think it's certainly a relatable topic. Where would you like to begin with sleep?
Well, I think a good place to begin is with good things. We all love sleep.
We do.
We spend a third of our life sleeping, no matter what age we are. And so sleep is something we all look forward to, and we need sleep, frankly. Our lifespans would be immeasurably shorter if we didn't have sleep because of its restorative properties. So, you know, sleep is created to keep the human body going, and we can't ever lose sight of that. So, having said that, maybe it's a good idea to talk about one of the commonest problems we have amongst adults, and certainly here, and that is insomnia. And it might be good if we talk about what insomnia is, because everybody has a different impression of what it means. Generally, people say, I can't sleep. So I can't sleep can be, it's a spectrum, it's a constellation of symptoms. So it may be you can't fall asleep. It could be that you fall asleep easily, but then you keep waking up and can't get back to sleep. Or you don't wake up that much, but you can't sleep through the night. And then when any of those symptoms are present, sometimes people will say, I can't sleep at night. And amongst the first questions should be, are you sleeping a lot in the daytime? So sometimes there can be a disturbed sleep rhythm. And for those who sleep late at night, you know, they sleep little at night. They may sleep 3-4 hours, but then they may be sleeping in the daytime. And the most dramatic example of this was one of our ex-presidents. President Clinton slept only 3 or 4 hours a night, but he took half a dozen daytime power naps. So it's important when we think about insomnia to recognize that it could be any one of those symptoms that are causing one to feel tired in the daytime because you're not resting well.
Insomnia with folks of our age tend to be something that has been a lifelong habit, or is it something that's developed with age?
So, you know, insomnia can occur at any age, but there's little question. And just to give you an idea, it's rather common. So 1/3 of adults have insomnia symptoms. I keep saying insomnia symptoms so that, you know, we don't think of it as just one symptom, because they can be different ones for different individuals. So 1/3 of adults. And then if you look at those above...
Of any age?
Adults.
Okay.
Yes, but if you look at those above the age of 60, 1 out of 2 individuals will have insomnia symptoms.
Oh, okay, so it's more prevalent.
Yeah, so in the general population of adults, we've got 60 million people who have insomnia, and it just seems to get worse as time goes on. About 10% of adults actually have what is called chronic insomnia. So insomnia is not necessarily the same. You know, people will sleep well for periods of time, and then there'll be periods when they don't sleep as well. But we consider it chronic insomnia if you can't sleep for more than 3 nights a week for more than 3 months. And that deserves a different kind of attention than the short-term insomnia. So some people may have had sleeping difficulties since they were little, but it's rarely constant, and it keeps changing over time. And so there are great opportunities to work with it and to help improve it. It's a very costly problem. Now, you know, these days every company looks at the bottom line. And in the case of insomnia, for our healthcare system in the US, we spend a lot of money on it. We spend about $15 billion a year Now, for the demographic here, it doesn't matter, but if you look at overall cost in terms of lost productivity, just like we talk about lost productivity with upper respiratory infections and colds, and we're talking about lost productivity in China with the coronavirus. So lost productivity with insomnia is about 4 times that number. It's more than 60 billion a year. Ooh. It's mind-boggling even to think of it, you know? And then, of course, apart from that, there is the cost of insomnia care. How much are we spending on things to manage insomnia? We're spending about 4 to 5 billion a year. So
well, and as you also pointed out, particularly with constant insomnia, it probably is going to affect our health.
Absolutely, absolutely. And you know, we should mention that there are many associations with insomnia, and we'll talk about risk factors momentarily. But depression is a very important one. The association between depression and insomnia is something that we really need to understand, because there are opportunities to solve the problem. We may be able to cure it, or at least to alleviate it significantly.
Why didn't we know about that in the past?
You know, I think we may have known about it, but we've not been as attentive to mental health as we have been to physical health.
No, I mean, this was news to me when you first told me this, that there was a link.
Yeah.
And I don't think the average person knows that.
Yeah, of those who have depression, about more than 80% have insomnia. So it's a huge subset.
It really
there.
does have an impact.
Yeah. So I think what is so interesting is to know why there's more trouble sleeping as one gets older, and certainly above the age of 60. So I'm going to mention 2 terms which folks may not be as familiar with. One is sleep latency, and the second is fragmented sleep. So before we talk about why those changes occur with aging, let me mention something up front, and that is sleep requirement doesn't change. So we still need that 7 or 8 hours of sleep. This is true that, you know, if there is a very sedentary lifestyle, and one is resting all the time, it may be hard to get those hours of sleep, because you know, if one is sitting and resting and falling in and out of sleep in the daytime, then the body recognizes that as sleep, so that sleep time is going to go down. So let's talk about sleep latency and fragmented sleep. So sleep latency is just simply a term that is used to identify that it takes longer to fall asleep. So this is a good time to take a quiz for one's own self and ask, you know, is it really taking longer to fall asleep? Because then you can identify where the problem lies. Is it taking longer to fall asleep? And if it is, then, you know, we've got treatment strategies which can focus on that.
So, a drug?
Actually, I would say cognitive behavior therapy, which we'll talk about later. Because if it takes long to fall asleep, there may be things that are environmental, you know, stimuli around you, sleep hygiene and things like that, which we'll get to later.
Okay.
So let's talk about fragmented sleep. So fragmented sleep, in medicine, we often take words just, you know, from the regular English language. And so fragmented sleep means just that. It means, essentially, it has 4 parts. As we get older, the quality of the sleep is not that good. So what we call sleep efficiency is reduced. That's the one component. The second component is that the total duration of sleep, the total sleep time is reduced. So quality is not good, and not sleeping long enough. I had somebody tell me yesterday that they sleep 4 hours a night. It's clearly not enough, and there will be consequences to that. The third component is, and I'm going to talk about the third and fourth together, sort of. The third component is that as we get older, the circadian rhythms may change. And so our body has a circadian rhythm for everything. So for instance, it has a circadian rhythm for blood pressure. And for those that I see, they know that when they check their blood pressure at home, I like to see a record which includes the morning blood pressure and a blood pressure about 4 in the afternoon.
I think we better define circadian rhythm.
So what that simply means is that our body has an outpouring of chemical substances, cytokines, hormones, which are secreted at certain times. And so the highest level of steroid hormones, for instance, is in the morning. And it's lowest in the afternoon. And so a lot of heart attacks and strokes occur in the early morning. And in the afternoon, most people experience a low, which simply means that the steroid hormones have gone down. And then you need a picker-upper at that time. So there's a change in the circadian rhythm.
If we could even be more basic than that, the circadian rhythm is a 24-hour rhythm.
Correct.
That's one of the biological clocks.
That's correct.
Having been a physiologist, I did some work on circadian rhythms,
Yes.
on biological clocks.
And
this is true of not just animals, but plants.
Oh, it's true of
it
everything. It's true of every cell system in our body.
Right.
So there's a
Exactly.
circadian rhythm for sleep, there's a circadian rhythm for, you just name it.
Right.
And there's a circadian rhythm for it. So
And
every
it
cell
goes entirely
in
through the-
cartoons you can see has a clock built into it as to how that cell is going to
Right.
function.
Right.
The gut, I mean, we've got a circadian rhythm for everything.
Yes.
So the circadian rhythms are altered. And as a consequence of the alteration in the circadian rhythm, our non-REM sleep. So we have two types of sleep, non-REMs and REM sleep. REM stands for, it's not a record label, REM stands for rapid eye movement sleep. So when we first fall asleep, we have non-REM sleep, which is longer than the next phase, which is the REM sleep. That's a much shorter cycle. And then these cycles keep repeating during the night, 5 to 6 times a night. And the number of cycles may be reduced, the duration of each cycle is reduced. So the non-REM sleep is reduced. Okay, and that's a consequence of the change, the down titrating of the circadian rhythm, for want of a better term. But at the same time, the slow wave sleep, the REM sleep, is also altered. So the sleep is fragmented because the total duration is reduced. Secondly, our circadian rhythm is altered. The non-REM sleep is reduced, and the REM sleep, which is when most people dream, is also reduced as well. And then the total duration is changed, the quality is changed. And that's what accounts for the fragmented sleep. And so, as I said, thinking about sleep latency, you can ask yourself, is it taking me longer to fall asleep? And which of those are you experiencing? Are you waking up once a night? Are you waking up many times a night? Are you waking up because you have to go to the bathroom? To be differentiated, but still an important corollary, because if we don't treat that symptom, it's going to affect sleep as well.
Yes.
You know. So this may be a good segue into thinking, what are the risk factors for insomnia? And some of them are
Yes.
obvious. We can't help our aging. That's upon us from the moment we are born. But for those above the age of 60, which probably includes almost, if not all, of the folks who live here, it is certainly going to be a factor. So medical conditions, example in point, chronic pain. Can't sleep when you have pain. It may be as simple as taking Tylenol before going to bed if you have trouble with arthritis, if you're just tired at the end of the day. Or it could be that there's an underlying medical condition, such as diabetes, which has many effects on, you know, the nervous system, the autonomic system, and we won't dwell on that right now because it's beyond the scope of what we can discuss. It could be medications. When you have a cough and a cold, there are lots of over-the-counter medications, some of which are sedating, and some which are meant to be non-drowsy. And certainly if they contain those stimulant type of drugs, those can keep you awake. So, someone may say, well, I took that cold medicine and I didn't sleep the whole night. There's a good reason for it, right? I think our community has learned well, or reasonably well, to avoid caffeinated beverages. I would say that for most people who have trouble with sleep, avoiding caffeinated beverages after the middle of the day, after lunchtime, is a good idea.
I read I read something recently in one of the health newsletters that caffeine has less effect on our ability to sleep at night than alcohol. That alcohol itself causes insomnia.
Yes, actually, I don't know that there is a controlled comparison of the two. That's probably a statement. There's a lot of information out there that doesn't have validation. There is no controlled study that has ever been done.
I don't think they were comparing. They were simply saying caffeine doesn't have a huge effect for most people at night, but alcohol does.
Actually, that statement is incorrect. I'm sure you read it, but there's a lot that we read,
Right.
But it does. Caffeine is a stimulant. And so it's not just coffee and tea. Coffee, of course, has a higher caffeine content if it's regular as compared to tea, but there are some sodas, and I don't see people drinking them here, but I'm going to mention them. So, for instance, Sunkist and Mountain Dew have a very high caffeine content. And now there's a lot of other beverages. In our quest to drink more water and not drink sodas, we've moved away from the sodas, and we've got beverages. So and many of them are quite good. There's one called Bai, has naturally occurring caffeine in it. And there are others that also have caffeine, but it's not apparent when you buy them that they contain caffeine. So that's, the downside. There is no beverage better than water, because, but I think there's some caffeinated waters out also, unfortunately.
I don't doubt it.
So while I'm at it, I'm going to make a pitch for drinking water from the faucet. The water in Fairfax County is good. The plastic bottles are just harming our planet.
Yes, indeed. I think
and
that
to be avoided.
every time I see somebody with a water bottle, bothers me.
The only reason to have a plastic water bottle is so that you can fill it, so you might know how much water you've drunk in the course of the day. Enough said about water. So what else do we want to talk about with risk factors? We talked about the link with depression. So certainly we want to mention depression. We want to mention anxiety. Now, there may be a generalized anxiety disorder, but sometimes anxiety can be a focus disorder. Some people are just very anxious about sleep. Others are anxious about time because they want to be very punctual. So the anxiety can be focused on something specific. So if the anxiety is focused on sleep, that in and of itself becomes a problem because you keep thinking, oh, I'm not going to be able to sleep. And you keep worrying about it all day.
There's an irony.
Yes, yes. And so, we have to think about that as well. So in everything that we talk about, we do broad strokes, because obviously we can't get into details of every risk factor. But I think that the anxiety, the depression, chronic pain syndrome are really important ones for us to focus on. The more highly educated folks are at greater risk because they may be overthinking everything. Maybe, I don't know.
I think the last time we talked about this, you said PhDs.
I did. I did.
And of course, that struck me as very funny.
I did say that last time, so I was trying not to say the same things again.
Okay, right. Yeah, that there was a there. That really struck home, but clearly.
Yes, and more women than men. And that,
is that right?
Yes, and that may be because anxiety disorders and depression are more common in women than they are in men. And we definitely have more women than men here.
Yeah.
Right.
Okay, I wasn't aware that there was a gender difference.
There is a gender difference. Yeah, there is a gender difference. So, what other questions do you have for me?
Oh my goodness. What kind of sleep disorders are you seeing?
So the commonest sleep disorder, of course, is insomnia. About 60 million people altogether. And here, as I said,
How do you treat it?
So we'll get to treatment momentarily, but just let me finish answering your first question. And then we'll talk about consequences and then get to treatment. So the second one would be sleep apnea. I'm sure many people here can identify with that. You have your
Yes.
CPAP machine, and if you do and you're not using it, this is a gentle reminder to use it, because that can help the insomnia. So if somebody has a CPAP machine and they've been letting it lie on the side, please put it to good use.
What kind of proportion or percentage of people have sleep apnea?
I couldn't tell you the percentage here because we don't mine our data, and I wish we would, because we've got an
Yes.
outstanding opportunity for that kind of research, but that's not something that we are able to do at this time. We should do it, and I wish that we would become activists for the cause of gathering that data. So overall, about 60 million adults with insomnia, about 22 million with sleep apnea. So it's roughly a third of the population has sleep apnea, rather common. The third one is restless leg syndrome, which is roughly half of that. So people can have leg cramps, but that does not mean they have restless leg syndrome,
Right.
but it's certainly there.
Is that associated with diabetes?
No,
Restless
not
leg?
necessarily.
Not necessarily?
No, not necessarily. And then there are some REMS disorders which are associated with behavior disturbances, which would have been, sleepwalking of the past, certainly not common. And then narcolepsy, which is the least common, but we do have individuals with narcolepsy. And there's specific treatment for narcolepsy. So with insomnia and with the sleep disorders, because sleep is not that good anyway as one is getting older, and if there's another sleep disorder with it, the question is, what is the risk? So what if you don't sleep? I mean, the consequences are obvious. And the most important that doesn't get talked about, everybody talks about increased fall risk, right? Because you're not as attentive.
Right.
But there's fatigue. If you don't sleep well, you're tired.
Right.
You're grumpy, So fatigue and mood disturbances, and there's a catch-22 here. There's more insomnia amongst those who are depressed, and those who have insomnia have a higher incidence of depression. It works both ways.
I would
it's
think
bilateral.
so, yes.
So it creates disturbances of its own, mood and behavior disturbances of its own. But there is a high fall risk, and that's very important to remember, particularly when we talk about treatment, because some of our drugs are associated with a high fall risk. So imagine that. You can't sleep, so you have a high fall risk, and then we give you a drug that increases your fall risk. So obviously we need to stem the tide there so we can prevent people from falling. So you'd asked me earlier about treatment. What can we do about treatment? So the most obvious thing and the most powerful treatment in medicine is the one that is curative, where we can find the cause. If we can find the cause, we should treat it, right? So if it's someone who's got sleep apnea and they're not using CPAP and we are giving them a drug to sleep, we're obviously not doing the right thing. So it's important to get a good history, to do our best to identify why the sleep disorder exists. If there's chronic pain, treat the pain. If there's depression, treat the depression. And there's some drugs which have a dual effect in terms of anxiety and depression, and those are very good for sleep. And an example of such a drug, and I'm jumping ahead a little bit, is trazodone. I'd never used trazodone until I came here, but now I prescribe it a lot, and it's a very good drug. It really, even the skeptics amongst the residents who've taken it have said that they have found it to be helpful.
Yes, I know a number of people who were taking that.
Yes. So treating the underlying cause is the first thing that we've got to do. Then the next step is, once we've identified what the abnormality is, and we really do need to assess mental health in this regard, for depression or other disturbances which are not that obvious in the course of a routine visit. Having done that, we can think about drugs for short term. And short-term drugs means essentially that you give it for a period of weeks or months. Our biggest problem is that once we give a drug, we never stop. I'm using the royal plural and saying we never stop means we providers need to make a concerted effort to discuss this and say, I'm giving this medication, but I'm only going to give it to you for a month, 2 months, 3 months, whatever. And then we have to stop. And the residents also have to accept that that should be the standard way for us to use these drugs. But then the residents say, well, if I don't take it, I'll never be able to sleep, or I will not be able to sleep. So there's a prejudgment involved that I will revert to where I was and I will not be able to sleep. And we need to encourage a more positive outlook and assess it rather than saying, okay, well, if you think you can't sleep, I'm going to give it to you, because then there's no stopping. One of our biggest problems with polypharmacy right now, whether it's sleep drugs or any other drugs, is we identify a start time and we don't identify a stop time, except for antibiotics. We don't identify a stop time.
Well, now stop and talk a little bit about addictive kinds of drugs.
Okay, so we've got, in terms of drugs for sleep, we've got over-the-counter drugs, and they are quite a scourge. So the Benadryl, you know, you can easily get that, any antihistamine.
Are those safe to take on a long-term basis?
No, they're not. They are good for allergies. They are not good for sleep. They create a hangover. They're not good for sleep.
No, they certainly do put you to sleep.
Yeah, they may, but you know, you are drowsy the next day. We don't want you to be drowsy, because being drowsy is setting you up to have a complication. You may fall. And so Benadryl is amongst the list of, there's all kinds of algorithms and recommendations available for drugs not to use in the elderly, and amongst them is Benadryl.
Is that right?
Yeah.
Okay.
Because there is a high fall risk.
Okay.
So they're there, but you know, we don't like to recommend those, and recommend, in fact, you not take them. The one that is safe to take is melatonin, because that is just causing, it has to be taken correctly. It has to be taken a few hours before you go to bed. If you're getting ready to go to sleep and before you get ready to lie down you take melatonin, it's not going to work. So it's going to help you with your sleep latency. It's going to help you sort of set the stage for you to go to sleep. So melatonin is good. So what about the addictive drugs? So unfortunately, in this category, we've got the what we call the benzos, such as lorazepam, diazepam, and temazepam, which should be used only for the short term. They are long-acting drugs, but they should be used for the short term. They should not be continued forever. Now, there are some who've taken them for a long time, and you can get addicted to them.
Okay.
So that's the reason why they should not be given for the long term. So because they were addictive and because they were long-acting, we had a new category of drugs come in, the non-benzos. Example being Ambien and Lunesta. So because they're short-acting, it was thought that, you know, we would do better with them because they're short-acting. No such luck. They produce their own problems, most significant being a very high fall risk. And now there are umpteen recommendations from umpteen groups saying these category of drugs should not be used. I'm pleased to say that Erickson many years ago decided that we should not use these categories of drugs, particularly Ambien. There was a concerted effort to discontinue those. And I have to say also that with the cooperation of the residents, we have been amazingly successful at doing that. I'm not going to say it's 100%, but it's been a pretty good number. You know, very few people now take those drugs, so that's a good thing. So maybe we should spend our last couple of minutes before we wrap up to just talk about cognitive behavior therapy. And I want to say that this should actually come very early in addressing sleep problems. There are cognitive behavior therapy, CBT for short. There are CBT centers. There are counselors for CBT. But in a nutshell, what it means is that we want to find ways to help you where we identify what is causing you in terms of your behavior from not sleeping. In other words, are you getting riled up? Are you reading exciting comics? Are you watching a horror movie? Don't do that. Sleep hygiene. Wake up in the morning, go to bed at the same time every day. control the stimulus in your environment. No blue light, no TV, laptops, phones for a couple hours. Wind down time, couple hours before you sleep, begin to take it easy. Read a boring book. Nothing
boring book.
Nothing exciting before you go to sleep. You know, relaxation techniques, deep breathing, anything that helps you take your mind off those things that are worrying you. But I think we should do a whole session on cognitive behavioral therapy because I think there's a great deal to be learned from it. It's probably time for us to wrap up, isn't it?
It is indeed.
Yeah.
We're down to the last minute.
Okay, so I think we should wrap up by saying that this is a common problem. And anybody who has it shouldn't feel that they're the only ones with it. They've been singled out for it. Know that there is hope. Know that you can work with your provider to find what's causing it. Also, please understand that anxiety and depression may be playing a big role in this, and we can help you with that. We've got counselors who can help you, treatments that can help you, and you know, just remember that if you're not sleeping well, it's really causing all kinds of problems for you. And we just need to make sure that a good night's sleep means a good day the next day. You'll be waking up on the right side of the bed.
Oh my goodness, that's a wonderful way to end this. And certainly that if you're having insomnia problems, talk to your physician.
Yep, absolutely.
Dr. Sethi, this has really been most interesting, and I think a lot of people are going to relate to this. So many thanks for your comments.
Absolutely.